Good evening, everyone. Thank you for joining us tonight. I'm Dr. Randy Mudge. I'm the physician in chief for Bronson's Regional Oncology Program, and we're very happy to host this event at Bronson tonight. This event is supported through generous donations to the Bronson Health Foundation in memory of Jim Gunderson. So Jim was an entrepreneur and business leader who served on the Bronson Healthcare Board of Directors for some 25 years. Unfortunately, he was diagnosed with prostate cancer 9 years before his death in 2021. His wife, Sally, who unfortunately just recently passed away, told us that Jim's biggest hope was to fund early detection of prostate cancer so that more lives can be saved. And upon her passing, I was asked that memorials be sent to the Bronson Health Foundation for the purposes of supporting educational events such as this. So this is our second annual event, and we're very pleased tonight to have Dr. Brandon Mancini as our guest speaker. He currently serves as medical director at Banff Health in Grand Rapids, Michigan, in the emerging field of theranostics. His primary clinical focus is the treatment of patients with metastatic prostate and neuroendocrine tumors. He completed his internship in internal medicine and residency in therapeutic radiology at Yale New Haven Hospital, which is part of Yale School of Medicine in New Haven, Connecticut. He also served as chief resident during his final year. He completed a clinical fellowship in nuclear medicine and radiomolecular theranostics in a nuclear medicine clinic in Germany. I won't even attempt to mention the town because I would totally mispronounce it. So I apologize for that. But without further ado, it's my pleasure on the behalf of the Bronson Health Foundation to welcome Dr. Mancini, and we're looking forward to his presentation.
Thank you so much. All right, thank you so much. Can you guys hear me if I move a little bit? This is working okay, hopefully online as well. But yeah, thank you so much for having me today, and specifically to Randy Mudge, Tanya Perry, and Scott Larson for inviting me. It's a huge honor and privilege to give this presentation this evening, and hopefully we can all learn a little something when it's said and done. So really in the next 45 to 50 minutes, the goal of today's talk is to really review prostate cancer at large, really from PSA to precision medicine, a modern approach to prostate cancer management, because as you'll hopefully see and learn, the way that things are going in all of oncology, truthfully, is precision-based treatments. So less broad treatments, more tumor-specific or patient-specific treatments, which is very exciting for everybody as we continue to increase quality of life and quantity of life with cancer. Here are my disclosures. And so the objectives today are quite broad, right? We're going to be talking anywhere from PSA to precision medicine. So that includes looking at epidemiology and risk factors for prostate cancer, go through some of the screening recommendations, and you can see there are some nuanced differences between societies and different task forces when it's all said and done. Look at kind of diagnosis of prostate cancer in general, looking at imaging and pathology, biopsy, other different aspects that we can add to that from an imaging perspective. You may be familiar with the PSMA PET scan, which is a prostate-specific PET scan that has really been kind of trailblazing over the last 4 to 5 years throughout the United States here. And specifically look at things like genomic classifiers and genetics and how that impacts treatment decisions for patients with localized prostate cancer and those with prostate cancer that has spread to different areas of their body. We're going to specifically dive into the localized disease treatment. The national guidelines has a way of categorizing localized prostate cancer, and then specifically look at radiation therapy radical prostatectomy or surgery in the management of prostate cancer, and switch gears and focus on the management of prostate cancer when it has spread elsewhere in the body. And there's typically two different statuses. When that first occurs, called hormone-sensitive disease, and when that's been treated for quite some time on testosterone blockade medications, where it's typically called either hormone-resistant or castrate-resistant disease. Finally, we'll touch on my current bread and butter, which is radioligand therapy, and Pluvicto being this very revolutionary medication that was FDA approved about 3 years ago here in the United States. If anybody are NFL football fans, you see a lot of these Pluvicto commercials, for better or for worse, during football games, which we'll see a lot of this year. And so a big change as to the landscape of management of prostate cancer. And so epidemiologically, prostate cancer is the most common non-skin cancer in US men, with a median age of approximately 67 years at diagnosis. The incidence does increase with age, and luckily mortality is declining due to early detection and therapy. And a lot of times people say prostate cancer is something that might be more or less inevitable for a multitude of gentlemen, but there's a whole degree of what that prostate cancer is, that incidence increasing with age, and you're more likely to die with prostate cancer than from prostate cancer. And while some of that is true, obviously it's very important to identify who are those gentlemen that do need treatment to ensure it does not shorten their lives. There are significant racial disparities. We do see a higher incidence in mortality in Black men. And that's something that continues to be an area of investigation and study to try to improve outcomes across all humans. And to most cases, luckily, are diagnosed with a localized stage and have a high disease-specific survival. Now, general risk factors, again, age, again, as the #1 risk factor. As we age, that's true of most cancers where the incidence increases over time. Family history tends to be relatively strong, so that's specifically first-degree relatives. So something like a sibling or a parent with a history of prostate cancer would portend a higher risk within the family. And then potentially our ancestry can contribute to that as well. There are also known germline variants, so genetic mutations in those 46 chromosomes of our body, specifically BRCA1 and 2, which historically breast cancer is typically affiliated with it, pancreatic cancer, melanoma, and others. But it does increase the risk of developing prostate cancer, amongst others, and other familial cancer syndromes as well. And we do know lifestyle does contribute to the development of prostate cancer, where obesity and low physical activity can portend a higher risk over time, where you can have dietary influence as well that might increase the risk, whether that's increased consumption of red meats, alcohol, amongst other things, or potential kind of healing effects or aspects of diet, such as vegetarian or vegan, that might allow for less total body inflammation and less development of cancer. Environmental exposures are a little bit more mixed, where we know that potentially a history of tobacco use or smoking can affect outcomes, but not necessarily the incidence of prostate cancer. But again, things continue to evolve each and every day as we learn more and more. So from a natural history perspective and just a key terminology perspective, these are some of the words and phrases that are thrown out with prostate cancer. You might have heard of kind of these words of indolent versus aggressive biology. And kind of like I alluded to at the beginning, is a lot of gentlemen are actually diagnosed with prostate cancer or may have undiagnosed prostate cancer as they age. And luckily, most of these are indolent or slowly changing type biologic patterns. Counter that to an aggressive biologic pattern, right? That means highly changing, highly variable, needing treatment sooner rather than later. Both in the indolent and aggressive, that can be at the time of initial diagnosis. That can also be in a setting of that prostate cancer having presented elsewhere in the body and how it responds to different treatments over a period of years, even if it is an incurable situation. Also, that a phrase that's used quite often is this clinically significant cancer. And historically, that's typically thought of to be this Gleason score 3+4 or grade group 2 prostate cancer, meaning clinically significant as in type of prostate cancer that needs a high consideration for some sort of curative intent therapy, versus clinically insignificant, more or less prostate cancer that is kind of incidentally diagnosed or may have that indolent treatment or natural history that might not necessarily need treatment now or ever. We also talk about things like biochemical recurrence. So PSA, or prostate-specific antigen, is a blood test that is used to diagnose prostate cancer. And biochemical recurrence means an increase in that number after some sort of curative intent treatment. And so whether that's prostate removal, this radical prostatectomy, or a PSA increase after curative intent radiation, there's different definitions for those and how we monitor it. And it's likely that those definitions will continue to evolve and change as we continue to get better at diagnosing things earlier and better with things like this prostate-specific PET scan that I mentioned. And then finally, low volume versus high volume. So this is a designation that's very helpful for medical oncologists and those that treat with systemic therapies, where there's literally level 1 evidence that shows that if you present with a large amount of prostate cancer that had spread outside of the prostate, you may benefit from some treatment escalation versus those with not as much prostate cancer spread outside of the prostate. So understanding that terminology and some of the things that are brought up at consultations and at meetings with oncologists and beyond is super important. Now, screening is something that obviously is very important for today's talk. And something that has been around for quite some time. And the goal with screening is truthfully to reduce metastatic presentation, right? Reduce the chance of cancer presenting outside of that curative state, outside of that prostate gland, while also minimizing overdiagnosis, right? So there's some risk when we screen for something where you may find a lot of nothings as a result, or one number could lead to a lot of tests and a lot of interventions that have cost and side effects and anxiety and concern, where ultimately that process may not be something that ever causes harm to that person. And so kind of a balance of a screening perspective in prostate cancer is to look at some of those factors. And then really kind of utilizing shared decision-making based on age, risk, life expectancy, and other factors. Because as you'll see with the screening guidelines from various societies, a lot of them are age-based. But as we know, age is just a number. And there's a lot of different kind of physical statuses that people might be in at a given age. And so using hard cutoffs based on age maybe is not the best approach for a lot of people. And typically the tools for screening would be things like your prostate-specific antigen, your PSA, right? A blood test that can be performed. Digital rectal examination was something that is a prominent aspect of screening, but honestly has kind of handed over to MRI and more advanced imaging tools as a result of improvement in diagnosis. But using things like MRI and others to really try to hone in on what's important, what needs treatment, and what does not. And so when we look at the American Cancer Society, screening guidelines really come into play at age about 50 for someone that's determined to be average risk, where they acknowledge the use of PSA screening and other screening at age 45 for folks that might have a first-degree relative that were diagnosed with prostate cancer at age less than 65, those that may be Black, and so forth, where age 40 comes into play if people have more than 2 or more first-degree relatives. So you're trying to understand that person's baseline risk and then adjust based on, again, not only what the guidelines say, but also what those patient goals are and where they're at in their life. And really with screening, PSA with or without digital rectal exam every 1 to 2 years is most common. A lot of times for gentlemen in this room, you might hear of or obtain that PSA at your annual physical with your primary care physician, which is a very normal, natural way to move forward. And really the guideline for American Cancer Society is really if you're determined that someone does not have a 10-year life expectancy, looking into kind of going away from screening might be in that person's best interest, again, because of that risk of overdiagnosis, procedures, tests, and cost and expense. Now, if you look at the American Urologic Association and then the United States Preventative Task Force on the next slide, you'll see that here it's really PSA-based screening at a slightly older age, really 55 to 69, where you can consider in that 40 to 54 age range if you have that higher risk population. And they leave that pretty broad on how that definition is defined. And really, again, really that 2-ish year rescreen rate in general, but really personalizing based on that person's PSA as you start going down that line and what their individual risk is based on their history and other factors. And again, in this setting, you see that bottom line, really avoiding screening in men that are greater than 70. Again, this random line in the sand, age 70 with limited life expectancy. And really the USP-STF is very similar to the AUA in these regards, except they're a little more bold with point number 2 on the slide, where age is greater than 70 or greater, they actually recommend against routine screening. And so a lot of PSA screening, prostate cancer related discussion has come up with former President Biden's diagnosis, right? Because rumor was that he hadn't been undergoing routine screening given his age and other things. And so it just shows you that that's not a perfect kind of all-inclusive way to approach. And again, we've kind of covered some of the harms of doing too much screening as well. Now, from a screening perspective, the evidence that supports that is robust. Really, prostate cancer screening does reduce mortality by upwards of 20%. But again, that risk of overdiagnosis, so that risk benefit, they've also shown that really with PSA screening, there really hasn't been in some studies mortality benefit. And the PROTECT trial was one where they actually had a randomization of gentlemen between pure active monitoring, prostate removal, or radiation therapy for low or intermediate prostate cancer. And they showed that overall prostate cancer mortality was quite low. But you did have a higher risk of prostate cancer spread with screening as opposed to active treatment. But they followed the patients 15 years out, and they did very, very well regardless, with basically a 97% survival rate on average for even untreated prostate cancer when it was first diagnosed. Thank you. All right, so PSA nuances to kind of refine risk, right? So there's age-specific PSA. It's actually very normal based on prostate size and age that PSA may increase over time. So it's important when you're analyzing someone's PSA to kind of know their natural history and trend and other factors that may be going on as well, prostate size and so forth. From a prostate cancer perspective, prostate size, right? BPH, benign prostate enlargement, carries with it kind of an elevated PSA at baseline. And so utilizing some of that baseline information is going to help your patient and you with decision-making regarding biopsies or other sorts of interventions. Percent-free PSA has been something historically utilized in an attempt to predict the presence or absence of prostate cancer. Honestly, it tends to be less emphasized in the setting of the modern era because with an elevated PSA, it is very common to at least consider getting a prostate MRI to further investigate whether there could be kind of a higher grade prostate cancer hiding out. And so certain things from a blood-based perspective have kind of been shifting over the last several years as a result of improvement in our understanding and our imaging in general. And a lot of times, if it's a single elevated PSA, the best thing that can happen is maybe you just repeat that PSA in a given period of weeks, because there's other things in life that can raise your PSA, whether it's exercise, recent instrumentation, kidney or bladder stones, riding lawnmower, things like that. They can actually all increase your PSA. And sometimes repeating that as a reconfirmation within a reasonable period of weeks can ensure that you're not over-diagnosing or kind of going too far beyond in your workup for that person. And there are risk calculators, again, that can be intermittently used or uniquely used. And it's really just risk stratifying to understand, like, how important is it to consider getting this MRI? How important is it to consider this biopsy? Both of which, again, cost, exposure to procedures, infection, risk, bleeding, things like that when it's all said and done. And so MRI has been something that has really been evolving over the last 5 to 10 to 15 years, where you're seeing more incorporation of prostate-specific MR in the utilization of diagnosis. And really multi-parametric MRI with what's called a PI-RAD system, really looking within the prostate every couple of millimeters at a super high resolution. There's a system to help identify the level of suspicion one would have, and these are typically prostate MRI trained radiologists reading these to help us figure out kind of how much we should be pushing for biopsy. And so this PI-RAD system goes from 1 to 5, where 5 is you're very convinced this is going to be something clinically significant, where 1 you're saying this has nothing to do with prostate cancer, and then you have anywhere in between. And typically with this system, if you have a PI-RADS 3, 4, or 5 lesion, that's going to help the urologist to do some targeted biopsies of that area, because that tends to be where the most at-risk prostate cancer is hiding. And so with a trial called Precision, they noted that MRI targeted biopsy did increase the detection of clinically significant cancer and decrease the risk of clinically insignificant cancer. And so that tends to be something that's done very, very commonly at this time. So now, if someone had a negative MRI, it doesn't always mean that you get the skip biopsy. That's when you might bring in some of these other pieces of information, right? The free PSA or some of the more advanced either urine or blood-based tests, or you still may proceed with what's called a systematic biopsy, kind of your standard template-based biopsy, just to rule in or rule out the presence of a prostate cancer, because MRI is still not a perfect tool. It's just a much better tool than we've had historically. And what's really interesting is there's been plenty of studies that shows likely the combination of kind of your 12 template targeted biopsy, that fusion of MRI and classic ultrasound, if you're doing both the targeted and systematic biopsy, you're actually the least likely to miss any clinically significant prostate cancer, which makes a lot of sense. But really just leading to better diagnosis, the right diagnosis, and then ultimately the right management for that person. So biopsy techniques, kind of as I was alluding to, so classic is systematic. It's typically a transrectal ultrasound, so an ultrasound placed in the rectum to visualize the prostate. And then there's 2 different approaches. What's tending to emerge now from larger academic institutions and then into the communities is what's called the transperineal approach, which is no longer biopsying through the rectal wall, but biopsying through the soft tissues of the perineum or the lower outside pelvis. And what that's been proven to do is actually decrease the risk of infection. And what I see as a provider when patients have had a transperineal biopsy versus transrectal biopsy is also commonly less of a risk of some sort of nerve-related irritation from the biopsy because the neurovascular bundles for the prostate are kind of in the back lateral or side parts of the prostate. And so you do see every now and again a patient with some chronic irritation after biopsy, which with the transperineal approach, you actually see a little bit less of that. And there's different reasons why that might be superior to a transrectal as well. But really the decreased infection risk, the risk of essentially no sepsis as a result of biopsy is one of the leading indicators. And kind of as I alluded to, really fusion targeted biopsy for these PI-RADS 3, 4, or 5 lesions, really to rule in or rule out clinically significant prostate cancer and ensure that patients are getting their appropriate diagnosis moving forward. Pathologically, when a pathologist is looking at this, we have something called the Gleason score, which has been around for many, many decades. Dr. Gleason really given us a score that when he looked at a prostate biopsy specimen, the way that I like to explain it is how much does that tissue that's been extracted on this little biopsy core, how much does it look like normal prostate versus not? And the less likely it looks like normal prostate, the higher the Gleason score. And biologically and systematically, kind of the more aggressive that tends to be. Now, you can imagine with a Gleason score, you're calling out the most common pattern you see under this little micro slide, and then the second most common pattern you see, and you simply add those numbers together. So you might have heard of Gleason 3 + 3 = 6, 3 + 4, 4 + 3. And they've really started to move away from that, really looking at just what's called grade group. because they simply just go 1, 2, 3, 4, 5. And so it kind of is simplified into 5 different categories instead of all this adding of numbers together to create the same sort of array of situations there. But we also look at how much of the prostate is involved, so core involvement percentage, and if there's other features that are classically associated with any sort of increased risk for aggressiveness when it's said and done. With biopsies, any sort of mild or minor surgical procedure, bleeding, infection, and then if the prostate itself, when it's been biopsied, if it gets inflamed and people have borderline urinary function at baseline, we may see some decreased urine function, blood in urine or sperm, things like that for some days or weeks after, typically resolves on its own. Now, with a NCCN risk group, so again, the whole purpose of biopsy is to help us figure out, like, is this indolent? Is this aggressive? Does this need treatment? Is this okay? Or do I need to do something sooner rather than later? And so you do have these NCCN, or what would be noted as national guideline risk groups that help us make those decisions. And it used to be just low, intermediate, and high risk prostate cancer, with a further subdivision in 2017 into 6 groups. So 3 groups became 6 into a little bit more of a nuanced way of kind of risk stratifying individuals. And this continues to evolve day by day, week by week, month by month. But really low, intermediate, and high risk disease with some nuance to get them very low, favorable, unfavorable, higher, very high. And you're really looking classically at 3 features. It's the PSA, it's the Gleason score or grade group, and then it's the tumor stage. So whether that's a rectal exam or an MRI, sometimes you're putting those 3 kind of factors together to create this risk group. And that's going to drive those initial recommendations for considering whether you can safely surveil or monitor your prostate cancer, or where treatment with prostate removal, radiation therapy, plus or minus some sort of testosterone blockade is medically appropriate for that situation. And what has really entered the equation, not only MRI and biopsy, but also MRI and staging, and then genomics to really personalize the treatment, right? You can think as if we're just looking at PSA in grade group in tumor stage, you could potentially have a very heterogeneous group of individuals. And so what's really neat is there's these genomic tests these days where you can send the tumor from the biopsy to various labs across the country, looking at tumor-specific features that are trying to help determine the aggressiveness of that tumor, not of a group that's heterogeneous in a risk categorization, but literally the tumor that was removed on that biopsy. And that can help kind of move up or down kind of the treatment decision or the utilization of androgen deprivation treatment with radiation and so forth. But these really have been an integral aspect of evolution, and a lot of these are now in the national guidelines to support that. Specifically, Decipher is called out quite often in the national guidelines as kind of this independent, very validated and trustworthy way of approaching prostate cancer management in the localized setting, amongst others. And there's a lot of clinical trials that are incorporating these biomarkers in this genomic testing, again, for better care, for more personalization, to ultimately get better outcomes with less side effects from treatment. Also, germline testing and then potential implications for targeted therapy is super important as well. So again, germline being the genes that we're born with, knowing whether there is an altered gene in that person's body is ultimately very important for potential treatment decisions if curative intent management is necessary. And this is very similar to those that might have colon cancer or even breast cancer in the setting of a known genetic abnormality that might portend less of a likelihood for something like an active surveillance, because ultimately that risk might be too high. It might also sway us to or against, for or against things like radiation therapy, if that person may have some inherent risk related to recovery from radiation or the risk of developing a second cancer from radiation 10, 20, 30 years later. So a lot of those factors go into play. And currently, germline genetic testing is really for high or very high risk prostate cancer that's localized, or for any patient where their prostate cancer has spread. And so again, initial staging imaging is risk adapted, where anybody that's diagnosed in this unfavorable, intermediate, high, or very high risk, they now all are able to get an insurance covered, FDA approved prostate specific PET scan, which is really a game changer when it's all said and done. So these prostate specific PET scans have been around for about 4 to 5 years. And it really is putting a whole new sort of magnifying glass and increased ability to know exactly what you're dealing with better than we ever have before. We really had classically things called CAT scans and bone scans to analyze the body. But bone scans don't have great sensitivity or specificity, and they show a lot of things that are not related to prostate cancer. And what's really amazing is PSMA PET, which stands for prostate specific membrane antigen, kind of overcomes a lot of that uncertainty and gives you over 95% confidence that what you see is what you get. And you're really making sure that patients are getting the appropriate therapy from the get-go. And now we have more confidence than ever that that is exactly what's going on. PSMA is also a unique protein that's overexpressed on prostate cancer cells. And so it tends to be at least 80, if not closer to 90% of prostate cancers have an overexpression of PSMA. And so it is a very good test for, again, 8 to 9 out of 10 gentlemen when it's all said and done, which is important to know. So we also utilize PSMA PET if the kind of PSA is going up after curative intent treatment. And so it's actually known to do a really good job at super low PSAs of finding what's responsible for that PSA elevation. Best example here would be if a prostate is removed, literally 6 to 12 weeks after that prostate removal, that PSA should be 0 or undetectable. And so if that's not the case, or in the future, if the PSA were to rise, we now have this really neat imaging modality that even with lower PSAs, we can find where that PSA is emanating from in a decent number of individuals. And what's really exciting is that this is only getting better. Definitely the higher the PSA, the higher likelihood that you're going to find something on that scan. But what's remarkable is there's new iterations of this PSMA PET scan coming that is finding it at even lower PSAs with a super high likelihood. For example, PSA nowadays, if someone's had their prostate removed, at least they should be meeting with a radiation oncologist to consider radiation therapy to where that prostate was removed from, really when that PSA is around 0.1-ish or so, 0.1 to 0.2. And your standard PSMA PET scan, currently that's FDA approved, has about a 40% chance of finding something on that scan, which is okay. It's better than anything we've ever had by a long shot. And if you're in that 40%, that's super important. Now, the next generation PSMA PET tracers have upwards of a 70% chance of finding where that's emanating from with these super low PSAs. So there's likely an almost doubling of our ability to see it when there's almost no cancer actually there, right? And so, because you want to make sure that if we're going to add treatments, if we're going to treat with radiation after the prostate has been removed, you want to make sure that you're encompassing the cancer in your treatment field ultimately so that you're not causing more harm than good. And so again, now more than ever, these things are advancing quickly and just becoming better each and every day. Now, active surveillance, kind of going back to that initial diagnosis. So active surveillance is something where if someone is diagnosed with grade group 1 prostate cancer, or classically Gleason 6 prostate cancer, as well as the grade group 2, which would have been called 3+4. If they've had their molecular testing, whether it's Oncotype, Decipher, Artera, any of those genomic tests, they've had their MRI, and so forth, it is very okay to consider active surveillance for some select favorable intermediate prostate cancer. Now, classically, if you look at the national guidelines, that's going to be a close monitoring situation is what active surveillance is. So PSA every 6 months, consideration of a digital rectal exam and or an MRI on a yearly basis. And you typically do get at least one new biopsy within the first 2 years of your first diagnosis, and then consideration of biopsy every 2 to 5 years, pretty much forever. And the reason why active surveillance is so attractive is because in a appropriately selected patient, 50 to 68%, so half to 2/3 of patients will not need treatment in the next decade. So, right, we want to avoid this over treatment. Half to 2/3 will not need treatment in the next decade. And then to counter that, well, what's the risk, right? Could it spread? The best estimates we have is that while you're watching this very closely like a hawk, that the chance of spread outside of the prostate is actually less than 0.5%, right? So that trade-off is typically very good, where that person may not ever need treatment for their prostate cancer, or if they can delay treatment for their prostate cancer for an extended period of time, that is a very good situation to be in for that individual. Now, other things to consider obviously would be standard of care curative intent treatments, right? So from a radical prostatectomy or prostate removal surgery perspective, when you look at the national guidelines for every single risk group, these are equivalent options, meaning radiation therapy plus or minus some testosterone manipulation and surgical removal of the prostate are determined and deemed to be equivalent options. And that's through at least a 15-year period of time. And so a lot of gentlemen do have options in choosing, if they're recommended to have definitive therapy, kind of which of the two approaches are best for them. And there's a lot of things that come into play there. But with prostate removal surgery, typically nowadays it's robotic or laparoscopic, and they do attempt to spare the nerves and the neurovascular bundles because that's going to lead to better urinary and sexual health kind of long term. When it's all said and done. Now, the goods and bads of prostate removal, you definitely get the final pathology staging. The expectation is a 0 PSA. You get the final pathology right. You make sure that you know exactly what's going on. And if someone has a lot of urinary obstructive symptoms, that potentially could be your one and done, where you're removing the obstruction, and maybe that's improving that person's urine quality of life. And removing the cancer simultaneously, right? So it's almost a 2-for-1. It also is potentially an option of the only one and done option for a high risk patient, meaning if someone had a little bit of Gleason 8 cancer, grade group 4 cancer, if they were to get radiation therapy, typically they have to be on medications that reduce their testosterone for upwards of 18 to 36 months sometimes. And so if someone may want to avoid that testosterone manipulation, and again, in theory, the only way to consider doing that safely is to remove the prostate when it's said and done. So some gentlemen prefer going down that route. And so the cons of surgery tend to be a higher likelihood of things like urinary incontinence or erectile dysfunction, but still very good rates overall on average. Now, radiation therapy is something that is internal, external, 5 treatments, 9 weeks, kind of has really evolved over a period of time. But these are some of the buzzwords that are utilized. Commonly, this IMRT or VMAT, this is intensity modulated or volumetric modulated arc therapy. These are all, I would just consider it super targeted, highly sophisticated treatment in modern day. SBRT is something that stands for stereotactic body radiation. That means 5 treatments or less. So super targeted, high dose, but you're done in a short period of time. Brachytherapy classically is seeds or catheters into the prostate that are only giving a radiation source into the prostate itself. And then sometimes we're combining these modalities for the higher risk individuals. But some of this is also going to the side to a certain extent, because now the external beam radiation technology has become so advanced that we can give a little bit more to the dominant nodule or the clinically significant prostate cancer in a kind of lower uniform dose elsewhere and kind of achieve something that doesn't require invasive procedures with really good long-term outcomes. Here's some of the radiation schedules that are considered. Again, 20 years ago, everyone was basically 9 weeks of treatment, where nowadays you can even get just 5 total treatments. So really what's allowed this to happen is technological advances. If we're irradiating an area where the prostate was removed, there's short-term data showing that a shortened course of about 4 or 5 weeks may be safe. But classically, those gentlemen are still under radiation therapy guidance for about 7 to 8 weeks of a more gentle approach, given the post-surgical nature. But again, continuing to evolve, continuing to get better, which is exciting. From an SBRT perspective, again, 5 treatments is the most common. Plenty of data showing this, that definitely in your favorable and unfavorable, intermediate, low risk prostate cancer, and even high risk prostate cancer, that we have good cancer control outcomes. And gentlemen with good urinary function commonly like this type of approach, right? If you can accomplish a goal in far fewer visits than 20, 28, or 9 weeks, with the same long-term cancer outcomes and side effects, obviously that ends up being quite attractive. And the community and academic experience continues to be quite robust. As I alluded to, brachytherapy, right, the seeds that are placed in the prostate or the catheters that are placed temporarily, that's done in specialized centers or locations throughout the state of Michigan and country. But really, it's becoming a little bit less prominent and prevalent because of the advances, how good the external beam radiation technology has gotten, and kind of the change even in training as to that approach. But it's something that's still utilized and still easily accessible for folks, Michiganders that are here. Proton therapy is a buzz phrase. The best data we have in prostate cancer is that honestly, proton therapy does not make meaningful difference for that patient in the long term. There might be slightly different short-term effects within the first 12 weeks, but no long-term differences for almost everyone. And so while it's a very fancy technology, an expensive technology in prostate cancer, with how advanced the technology is just with this IMRT, VMAT, SBRT, et cetera, there tends not to be an advantage to going forward with proton therapy. And then we also do, as I alluded to, radiation therapy after the prostate's been removed. If the PSA is increasing, sometimes you're doing radiation therapy to kind of sterilize any microscopic cells that could have been left behind, whether it's margins at the time of surgery, meaning some microscopic cells in the area of the bed, or other high-risk factors. Radiation therapy can be utilized after prostate removal to make sure that outcomes of those gentlemen with the removal are equivalent to radiation long-term. So pros and cons of radiation therapy: really, pros is that organ preservation. You get the equivalent cancer control long-term, but that you are having an external source enter the body, and so there is some risk to bowel and bladder. Luckily, long-term severe side effects with modern-day technology are very, very minimal. And we have things like gel spacers that can be placed between the prostate and rectum, and other ways to kind of minimize the effects to the neighboring tissues, which are very exciting when it's said and done. Now, with radiation therapy, also for these unfavorable, intermediate, or high-risk patients, they do need to have their testosterone reduced for a period of time in order to get the equivalent long-term outcomes compared to just that pure removal. And so sometimes patients have concern regarding their testosterone being physically zero for a defined period of time and the side effects that go along with that. But luckily, most gentlemen do tolerate that quite well, and it tends to be a temporary period of time to ensure that the next 15, 20 years have the best outcome possible. Things after radiation therapy can also be considered. Luckily, this also is quite a rare situation with a modern approach. But if someone had prostate cancer return in the prostate alone, and it's been some years after radiation, there are roughly 8 to 9 different things that can be considered, including just pure observation versus repeat radiation, cryotherapy, so freezing that area that returned, maybe putting seeds or catheter-based radiation just into that recurrence, hormone therapy, et cetera. And so really, again, long-term, we're seeing similar outcomes over time between radiation therapy and radical prostatectomy. And so it's really a quality of life trade-off. And some of these discussions are the longest discussion with the patient, because it's a hard thing, right? No one wants to do any of this, but you're trying to pick kind of what meets their needs and where they're at when it's all said and done. And so we've talked about side effects. So from a metastatic prostate cancer perspective, really that high volume versus low volume is kind of the backbone of how we classify that. And that was classically looked upon as high volume prostate cancer being 4 or more bone lesions from prostate, and at least one of those bone lesions outside of the spine or pelvis, or if there was organ involvement like lung or liver. And recent data has shown that actually intensifying treatment, meaning kind of throwing a lot of treatment at that cancer at the outset, can lead to improved overall survival long term. And so again, This is to be discussed with a medical oncologist, and we do a very good job here in Kalamazoo, Grand Rapids, the state of Michigan, at kind of staying on top of advanced cancer care and ensuring patients get the optimal approach. But different considerations that come into play, whether chemotherapy is added up front or not when it's said and done. But as we were alluding to, really this ADT, or androgen deprivation therapy, plus androgen receptor pathway inhibition, so basically blocking testosterone from stimulating the prostate cancer, is really that backbone of treatment. And in general, patients do tolerate it pretty well. But you do have patients now and again with things like hot flashes, fatigue, muscle wasting, or metabolic changes that may not make them as comfortable over time. And from a chemotherapy perspective, there's typically two major chemotherapeutic agents, and again, kind of risk adjusted based on that person's presentation. When patients are on long-term testosterone manipulation, they are at risk for their bones getting a little weaker over time. So sometimes bone support is important because testosterone is responsible for ensuring our bones are good and strong. And just treating with patients that have lesions in the bone as well might place them at higher risk for bone-related events. And so kind of addressing that up front. So again, androgen deprivation therapy adverse effects. So hot flashes, right? Like when women go through menopause, it's a very similar phenomenon where gentlemen might have just random flushing throughout the day or primarily at night. But having your testosterone manipulated and pressed down to zero could have you develop things like metabolic syndrome. So weight gain, metabolic slowing, right? Muscle loss, fat gain, etc., bone loss, even cardiovascular events. But luckily, there are ways to try to counteract this as much as possible with kind of your classic things, right? Diet and exercise, bone agents, keeping on top of things. But it could require increasing exercise from baseline or reducing added sugars or carbohydrates that normally would have been well tolerated, but with the slower metabolism, now it's not anymore. And so again, with a medical oncology backbone of care, it's super important to continue to bring these up and for this to be assessed throughout that treatment. You also have kind of situations nowadays, especially with these PET scans, that we might see a situation where someone presents with maybe one or two spots of prostate cancer outside of the prostate. And very commonly how this is approached is, and this status is called oligometastatic, or very few areas of cancer outside of the primary organ. And a lot of times what happens is we go very aggressively with treatment in that case. And so this is much different than what was going on 10 years ago, where we couldn't even see these areas to even know that they were a problem. And now things have swung very strongly to not only treat maybe with curative intent on the prostate, but also to definitively knock out those areas that presented on that initial imaging, which is starting to manifest into better outcomes long-term and more time off treatment. Even if the cancer were to recur in the future with this more aggressive management, if patients can have windows of time off treatment, right, where their testosterone can come back to normal for periods, that's super meaningful from a quality of life perspective when it's all said and done. And then finally, in the metastatic castration-resistant setting. So this means they've been on the testosterone blocking medicines, but now the PSA is rising or new cancer spots are forming despite being on those blockers. If someone's just been on a primary testosterone blocking medication, then you tend to add the secondary testosterone blocking medications. But you also might then be introducing things like what I do each and every day, this Pluvicto, or this targeted radiation medicine, and or chemotherapy, and or really targeted agents that might take advantage to some of those genetic or genomic alterations that we reviewed earlier. And so again, this is typically just a multidisciplinary discussion with urology and medical oncology and radiation oncology to determine how best to individualize treatment for people moving forward. Here's some of those medications again, and some of those key trials, but again, all showing that these agents are active, that they improve overall survival, that they improve time for any sort of progression of that person's cancer. And then finally, radioligand therapy, again, kind of taking over at least a lot of the buzz within the prostate cancer space because of that FDA approval of the drug called Pluvicto back in March of 22, where it's literally a 30-second injection, and that medicine is designed from an organic chemistry perspective to literally just go stick to the prostate cancer that we would have seen illuminate on the PET scan done within weeks to when you start treatment. And so currently that's not typically a curative intent treatment, but because of how targeted this medicine is, you really just drink a lot of fluid and you have an aggressive treatment, as aggressive as chemo, but it's just sticking to the prostate cancer cell and literally going inside of the prostate cancer cell, giving radiation from the inside out within 1 millimeter of where it's sitting, 24 hours a day, 7 days a week. It lasts for about 6 weeks. And then you do repeat that therapy multiple times. Again, most people tolerate it without literally missing a beat. We have people golfing, fishing, gardening, doing whatever they want, pickleball, the day after treatment with no downtime. And these are cancers that were aggressively changing, and now they have a really good chance of having a response to these sorts of treatments. And so just a wave of the future, what these radioligand therapies can do. And so what's been really interesting is just to see the evolution over the last 3 years, because those top two are the trials that led to its approval here in the United States. But literally just March of this year, it was required that someone had trialed chemotherapy before they get Pluvicto. And that was really just something that in Germany, Australia, and other countries that they've been doing Pluvicto-like medications for quite some time, but we finally had maturation of data showing that using Pluvicto before chemotherapy actually does a lot of good for preservation of quality of life, quantity of life, and response to such treatment. And so it's not that chemotherapy is being replaced, but sometimes changing the sequence with which we give these treatments, you might be actually maximizing the quality and quantity simultaneously, which is obviously what we all hope for. And so what's really interesting is kind of like I said, you do get this PSMA or prostate-specific PET scan to confirm that people qualify. There are some normal kind of baseline bone marrow characteristics and kidney function characteristics that need to be considered. But it's a very exciting aspect of prostate cancer care. And really, future directions within this space are that these radioligand therapies are continuing to move earlier. And so it's likely in the second half of this year that they're submitting to consider moving Pluvicto all the way up to the first time someone's diagnosed with prostate cancer outside of the prostate. Still in combination with other treatments, but again, maybe that concept of being a little more aggressive in the beginning can ultimately buy, again, quality and quantity. There's evolution of this space where we have stronger radiation medicines coming that might allow for more durable long-term responses, or just adding more tools to that tool chest to allow assistance for managing patients throughout their journey when it's all said and done. We also have combinations of medications within the medical oncology space where the blockade of androgen receptors, adding additional treatments with that, right? These combinations to try to take advantage of multiple pathways of resistance at once is a way to continue to evolve and assist people for better, earlier, more durable responses. And then really using artificial intelligence, right? That's kind of the buzz of both the healthcare and non-healthcare world and so forth. But that is coming into play quite often, not only in what I do each and every day, but some of the decisions that we all make where you'll likely have complex kind of factors where you can input patient characteristics in, and it might assist us in determining the best next step for that individual based on a lot of both quantitative and non-quantitative features. Also liquid biopsy, right? There are patients with neuroendocrine differentiation prostate cancer or just super low PSA producing prostate cancer, where you might be able to do a blood test, and you can, and you see fragments of DNA of prostate cancer floating around. And maybe that makes PSA obsolete for patients if you're monitoring the fragments of DNA floating around, where you're finding information out both earlier or understanding responsive therapy in a different way. And this is something we've seen in colon and rectal cancer, some neuroendocrine tumors, et cetera, but a lot of unique advances and changes that are very exciting. So again, overall, I do have some summary slides here, but really patients, again, I think the biggest take home is just the volume of change that's happened in a relatively short period of time just for prostate cancer is pretty remarkable. And outcomes are better than they've ever been and will continue to be that way. I was doing a webinar just a couple days ago with medical oncologists from Mayo Clinic and Johns Hopkins who have been in the field for 20 to 30 years. And how impressed they are with how things are now versus just 10 years ago is kind of says the most to me, because they saw it when there was almost no options. There were almost no things that could offer. The average life expectancy if prostate cancer was outside of the prostate was 6 months. And now we're talking many years for most people, which is very good. And so now it continues to evolve, right? Precision, specificity for an individual, maximizing quality while maximizing quantity, and understanding that together, working as a team with the patient and their family and friends, most importantly, to get these great outcomes. And so I think overall, I mean, this scenario here, right, this is what we all yearn for, which is we don't like what's going on the left, right? There's spots that are outside of the prostate, but delivering effective therapies that can create absence of prostate cancer, absence of PSA, peace of mind, and better outcomes for each individual. And I think, again, we're in better position now more than ever for this unique thing. So I appreciate being here so much. And just to give that little plug for the free prostate exam here at Bronson, both Kalamazoo and Battle Creek, occurring here September 9th here in Kalamazoo, and then September 23rd in Battle Creek. PSA, rectal exam, kind of everything necessary to ensure that people are safe and healthy and have that chance to make sure that prostate cancer is not a part of their future that's going to cause harm. So thank you very much, and happy to take any questions. Oh, absolutely. Yeah, both Kalamazoo and Battle Creek and all of Southwest Michigan. I mean, we're very lucky in the state of Michigan to have all the necessary resources to accomplish the best outcomes for prostate cancer care. Absolutely. Yeah, the majorities are. I think there's still some indications where open is done, but robotic really, it all seeds from like the original training for people. And so that there's been a large swing over a multitude of years at this point, but definitely robotic tends to be the majority. And there's various approaches. There's ways, again, of the nerve sparing, and there's continual evolution of advanced techniques, where those sorts of more advanced techniques would be at specialized academic centers. But absolutely, Kalamazoo, Battle Creek, Grand Rapids, all of Michigan, we have robotics and highly advanced surgical techniques. Yeah. Yeah.
Types of outcomes and treatment plans for people with prostate cancer?
Yeah, that's a great question. I think in general, I mean, history of any sort of STIs, STDs, or any immune dysfunction, whether it's someone with a transplant on immunosuppression or HIV on antiretrovirals, I think either way, they may facilitate prostate cancer development in someone that already has a baseline risk, meaning if you are kind of prone or exposed to a lot of infections and inflammation of the prostate over time, inflammation can create kind of a chronic area of concern and potentially translate into prostate cancer years down the line. From a treatment perspective, if people have a compromised immune system, whether it's natural or not, then sometimes there can be less of a robust natural immune response, right? So in radiation therapy, a lot of the value is creating localized controlled damage to the DNA of the cancer, and then your immune system helping kind of respond and kind of clear things out and so forth. So it's possible that someone that has HIV or again on transplant on immunosuppressants, they may not have as robust in certain situations. as far as a response to certain treatments. Now, the data is pretty mixed on that, but that's absolutely a consideration where maybe that's where your surgery versus radiation therapy discussion might change depending on the overall health status of that person as well. But I think big picture, yeah, inflammation can cause some changes and some difficulties and potentially increase the risk long term of prostate cancer, because we know even non-infectious inflammation of the prostate can do that. And then again, people with some sort of immunocompromised status may not have as good of outcomes, but still very good outcomes in general. But honestly, numbers are pretty small over time to really make defined kind of conclusions from what we have. So, yeah. Yeah.
Could you repeat what the active PSMA is for?
Yeah, PSMA is prostate specific membrane antigen. So PSMA, and again, really, it's literally this protein that sits in the cell wall, cell surface of a prostate cancer cell, and it tends to be overexpressed. So there's a lot of PSMA on prostate cancer and not so much on normal prostate tissue. And so now all of a sudden you have an imaging modality that can really illuminate the problem and help with that optimal diagnosis. So.
Okay, well, thank you. Want to thank Dr. Mancini for an excellent presentation. And thank you all for coming tonight. And for those of you who joined us on Teams, thank you also. The plan is to continue this as an annual event. So if you do have any feedback, please let us know, and have a wonderful evening. Thank you. Exciting field. I've been doing this for 30 years. We've come a long way. Back in my day, we used to do 4-field box.
Yeah, right.
Yeah.
Well, and I'm sure you see it all the time. You still have patients that know somebody that had some toxicity.
Oh, yeah.
But I tried to explain, like, anything after 2010, people just do so remarkable, and it's exciting.
Yeah, they do. I was telling someone the other day that I had a case of proctitis, and probably like you said, 7-8 years. So, which is great because back in my early career, it was an issue we all had to deal with. And
Yeah.
it wasn't fun.
No.